This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Acta Neurosurgica, published in 2026. The paper is titled A Simple and Aesthetically Pleasing Floating Craniotomy, How I Do It, by Tianzhen Li and colleagues from the Army Medical University in Chongqing, China.
This is a topic that hits home for anyone who spends time in the neurotrauma bay. We're all familiar with the classic dilemma of the decompressive craniotomy, or DC. While it's a life-saving procedure for managing refractory intracranial pressure, the subsequent morbidity and the necessity of a second surgery for cranioplasty can be significant. We've seen the literature, like the 2015 Curlin study, highlighting these challenges.
Exactly, Dr. Aris. And while bone flap preserving techniques like floating or hinged craniotomies have been around to offer ICP control, the optimal technique is still a matter of debate. This paper presents a very elegant, adjustable solution that bridges the gap between a full craniectomy and a traditional closed craniotomy.
It's all about finding that sweet spot in the Monroe-Kelly doctrine. We know the combined volume of blood, CSF, and brain tissue must remain constant. When we have trauma or swelling, we need to expand that container. But do we always need to leave the bone in the freezer or a subcutaneous pocket? The authors here say maybe not.
Right. Let's dive into the technical description. The authors advocate for a standard large craniotomy first. We're talking about a bone flap measuring at least 12 by 15 centimeters. They emphasize that you still have to do the heavy lifting. Adequate temporal decompression is a must. You have to remove the temporal squama and the lesser sphenoid wing down to the floor of the middle cranial fossa.
That's a critical point for the residents listening. A floating flap isn't an excuse for a small opening. If you don't get down to the floor of the middle fossa, you're not truly decompressing the areas that matter most. Now, once the intradural work is done, the hematoma is out, the hemostasis is solid, how do they decide if this floating technique is appropriate?
The authors are very specific about the intraoperative test. They state that if there is no significant brain swelling, or if the swelling is mild and doesn't exceed the cranial surface, you can replace the bone flap. If the ICP remains under 10 millimeters mercury after replacing the flap and attempting to approximate the scalp, then you're a candidate for this floating procedure.
So it's for that patient who is on the fence, not the fulminant malignant edema you might see in a massive middle cerebral artery infarct, but more common in traumatic intracranial hematomas where you expect some edema, but perhaps not a catastrophe. Walk us through the suture technique, Alara. This is the secret sauce of the paper.
It's actually quite clever and uses materials every OR has. They use a 1 millimeter high-speed burr to create 3 pairs of drill holes, one group each in the frontal, parietal, and occipital regions, distributed symmetrically.
And they use OO-proline, right?
Yes, a non-absorbable OO-proline. For the frontal holes, they place them about 1 centimeter from the edges and tie a standard surgeon's knot. But, and this is key, they leave a relatively large loop. This allows the bone flap to move upward as the brain swells, but the loop acts as a tether to prevent the flap from displacing or sliding too far.
But the real innovation is in the parietal and occipital holes.
Exactly. In those positions, they use adjustable slip knots. They leave at least 2 centimeters of slack to permit that outward bone flap excursion. But here's the kicker. They exteriorize the ends of those slip knot sutures through the scalp.
That's the adjustable part. It's like having a remote control for your bone flap tension. But if the flap is floating with 2 centimeters of slack, what's to stop it from just sinking back down or tilting awkwardly?
They addressed that with a simple hardware trick. They secure one end of a titanium plate to the bone flap with a screw, usually in the parietal or occipital region. This plate acts as a stop to prevent delayed flap subsidence while the brain is still in the recovery phase.
I also noticed they mentioned the surgical anatomy of the scalp in the paper. Why did they emphasize the 5 layers?
They really focused on the loose areolar tissue, that 4th layer between the galla and the pericardium. They perform a blunt subgaleal plane dissection around the incision. By mobilizing the scalp in this layer, they increase scalp mobility and compliance. This creates the physical space for the bone flap to actually move outward when the ICP rises. Without that dissection, the scalp would just act as a second rigid container.
It's a great reminder that neurosurgery is as much about the soft covers as it is about the hard case. Now, let's talk post-op. The patient is in the ICU, the bone is floating under the scalp, and the suture ends are sticking out. What happens next?
They do standard dressing changes every 2 to 3 days to keep things sterile. They monitor the patient with clinical exams and CT imaging. In the paper, they show a case where on postoperative day 3, the CT shows significant edema with good elevation of that floating flap. By day 9, the edema has resolved.
And that's the moment of truth. How do they tighten the flap without going back to the OR?
It's a bedside procedure. Once the edema is down, they apply an elastic compression bandage to help guide the bone flap back to its anatomical position. Then they take those exteriorized slipknot sutures. To tighten them, you stabilize one suture limb with a hemostat and use a second hemostat to gradually tension the contralateral limb.
And once it's snug?
They trim the sutures at the skin level. They recommend continuing the elastic bandage for another 2 to 3 weeks to ensure the bone flap stays fully secured while things heal. In their follow-up CTs at 3 months, they showed satisfactory anatomical reduction with no subsidence and, importantly, an excellent cosmetic outcome, no sunken flap syndrome.
Which is a huge win for the patient's quality of life. But we have to be realistic. This isn't for everyone. Let's talk about the limitations and the traps the authors want us to avoid.
This is definitely not for malignant edema. The authors specifically mention large area cerebral infarct as a relative contraindication because this technique offers limited decompressive volume compared to leaving the bone off entirely. If you have fulminant swelling, you need a traditional DC.
And what about complication avoidance?
Their list is very practical. First, strict patient selection. Don't try this on a brain that is already herniating on the table. Second, position your drill holes away from major vessels to avoid unnecessary bleeding. Third, meticulous hemostasis. You don't want an epidural hematoma forming under a floating flap. And fourth, protective positioning. You have to make sure the nursing staff knows not to let the patient lie directly on the operative side, as that could displace the flap.
I think that's a vital point for the residents. You have to communicate with the ICU team. This isn't a set it and forget it procedure. You still need ICP monitoring and ICP-directed management to detect any abnormalities early.
They also emphasize infection control. Having sutures exteriorized through the scalp sounds like a risk, but they argue that with strict aseptic technique, standard antibiotics, and diligent wound care, it's manageable.
Let's summarize the key technical takeaways for our listeners. If you're going to try this, what are the must-dos?
The flap must be large, at least 12 by 15 centimeters. You must achieve full temporal decompression down to the middle cranial fossa floor. Use a stellar or semicircular dural incision with expansive duroplasty or an artificial substitute. Establish those 3 suture fixation points, a large loop surgeon's knot at the front, and 2 adjustable slip knots with 2 centimeters of slack at the back with those ends exteriorized. And don't forget the titanium plate on the bone flap to prevent it from sinking later.
It's an interesting middle ground. It addresses the Monroe-Kelly needs of the acute phase while planning ahead for the aesthetic and physiological needs of the recovery phase. It effectively turns a 2-stage surgery into a 1-stage surgery with a bedside adjustment.
Exactly. And for the medical students listening, it's a perfect example of how understanding basic anatomy, like the layers of the scalp and the physics of the skull, can lead to innovative surgical techniques.
Well, that's a wrap on this episode. Thank you, Dr. Alara, for breaking down this study. It's certainly a technique to keep in the toolkit for the right patient.
Thanks for having me, Dr. Aris. It's always exciting to see how simple mechanical solutions can solve complex clinical problems.
To our listeners, you can find the full paper in Acta Neurosurgica 2026. Join us next time on the Neurosurgery Hub podcast as we continue to explore the cutting edge of our field. I'm Dr. Aris.
And I'm Dr. Alara. See you next time.